Good morning. Welcome to the December 14th, 2017 Public Health Nursing Webinar. My name is Joy Hoskins. I'm the Chief Nursing Officer for the Department for Public Health. I apologize for our few-minute delay. We've had some technology hiccups. And I don't know what I do without technology hiccups, so we'll put those in as a part of our daily routine. And I'm so glad that you're able to join us today. We've got a full agenda, and I really feel like there's going to be some great information shared with everyone. This session will be archived as per our normal routine, and so if there's someone in your agency who's not able to join us today for the live presentations, please know that this webinar will be available via archived webcast within a few days. The first presenter that I have today that's share with us is Dr. Jonathan Ballard, who is Kentucky's new state epidemiologist, as well as the division director for the Division of Epidemiology and Health Planning. And Dr. Ballard, I've invited him today to provide us with a acute hepatitis A outbreak update. As you all may know, the Department for Public Health declared public health outbreak for hepatitis A on November 22nd, the day before Thanksgiving. And so there's been a lot of activity related to this outbreak. Many of you may have been participating on calls and providing information, providing vaccinations, hepatitis A vaccinations. So I'd like to invite Dr. Ballard to come up and provide us with an update to see where we are in this initiative and strategies to mitigate this outbreak across the state. So Dr. Ballard, thank you very much for coming, being with us today.
How much time do I have?
You've got about a half an hour.
Great.
Great. Hands here.
Slides up. Great.
Camera's right there, Dr. Ballard.
Good morning. So thank you, Joy, for the introduction, and it's a pleasure to be here at the Kentucky Department for Public Health and to work with all of our partners at the local health departments and the independent health departments and districts. Since my time here at the Kentucky Department for Public Health, we've had a number of investigations in different diseases, and this one is one we're in the middle of right now, acute hepatitis A. And so what I thought I would do today is to share with you kind of an overview of what is hepatitis A and where we're at with the epidemiology and the statistics, and then really talk about what we're doing and then what we need your help to do in order to mount our public health response and bring this outbreak under control. So very much thank you for your work that you do regarding epidemiology, the disease outbreaks. I know much of the work that you do in the local health departments is consumed by a lot of the requirements that you have to perform with the clinical services and the day-to-day operations that you do. And so sometimes, I realize that case reporting is something that can be an extra added work to your work that you so valuable do in the health department. But I just want to thank you so much for all that you do with the outbreak investigations, the calling of patients, the calling of healthcare facilities, and finding out the clinical data and contact data that we can all use to share with each other to know where to target our response, tailor it down to the kind of the lowest sources of the outbreak. So with that, we'll go forward. So let's see if I can bring up slides and advance them. I need to push this or something. There we go. I always have to say this, I have no financial disclosures to announce. Okay, so multi-county outbreak in Kentucky, and it was declared just shortly there before Thanksgiving. Initially, we had about 31 cases of acute hepatitis A that we were recognizing. Typically, on average, for the last 5 years, we had 20 cases on average for the entire year for the entire state. And so we were up a little bit, 31, enough to say this is something that we should be paying close attention to. But looking further, the majority of the cases were in Jefferson County, and so we knew we had to further investigate this, the risk factors associated with it, and determine what's happening. So what is acute hepatitis A? Well, hepatitis A is an illness that affects the liver. It has oftentimes non-specific symptoms, but if there are symptoms, they may include fever, headache, abdominal pain, nausea, vomiting, loss of weight, and jaundice. And jaundice is yellowing of the skin or of the white parts of the eyes, and that's one of the main symptoms. A clinical finding or a lab finding is elevated liver enzymes. And liver enzymes are often known as ALT or AST, and we see those elevated when the liver is not functioning as it should, when it's inflamed. And for all diseases, the CDC and the Council of State and Territory Epidemiologists set what is the definition of a public health condition or a disease. And for this, they say you have to have one particular lab elevated called an IgM, immunoglobulin M. It's the first antibody that our body creates in response to the hepatitis A virus. It also could be a case of acute hepatitis A if we don't have that lab finding, but we say it's epi-linked, meaning that we know somebody has acute hepatitis, but they're connected to somebody in the household or some other close contact that they have. It is a known hepatitis A case. So in that situation, you would not have to have the laboratory finding to say it is an acute hepatitis A case as far as public health. Hep A is a fecal oral transmission route, meaning microscopic amounts of fecal matter is involved usually with the transmission of Hep A. It can be placed on any kind of surfaces, doorknobs, toilets, anything like that, or hand-to-hand transmission, and that is a known case. And I'll go a little bit into the biology of that. Unfortunately, Hep A is transmitted from person to person before the person even knows they have any symptoms, before they're sick at all. And so that what makes this really tough for us from a public health response and getting it under control quicker, because it's spreading before a person is known to be sick. Now, they continue to be what we call viremic, or shedding hepatitis A virus in the stool after they are sick, so there is an opportunity there. And there are treatments for people who are in close contact with a known hepatitis A case called post-exposure prophylaxis, or PEP. So if you were in close contact with somebody that's known hepatitis A case, you should have PEP, and that is a role in public health for us to do the contact investigations and then to encourage PEP. And so, in our role in public health of assurance that services are available, it would be good for us to know where PEP is available in our local community if it's not able to be provided at the local health department. So PEP is included for those that are unvaccinated, would include a vaccination to hepatitis A, as well as immune globulin that's approved for hepatitis A virus. And that's indicated for anybody who's in close contact to a known case of hepatitis A. So laboratory-wise, IgM goes up in response to a person having exposure to hepatitis A virus. And then later on, there's a confirmatory test where you can actually test for the RNA of the virus itself in a blood sample. And we do that at the Kentucky Department for Public Health. And we're asking that any case that's being investigated in the state for Hep A to have an additional blood draw. And we've sent out laboratory guidance to all the local health department listservs. Joy has sent this out. It includes a couple of things. It includes a one-page questionnaire that we ask you to go ahead and encourage your medical community to do whenever they have a suspected case, because, again, because of the biology of this disease, we really need to know as soon as possible who are the potential close contacts in order for PEP to be administered to get this under control. As well, and so we'd like an extra vial of blood for be saved at your local community if they're willing to do so. and then sent on to the state for confirmatory testing if that IgM initially comes back positive. The CDC has asked us if any case comes back positive to also send it on to the sample to them, and they will do something new, amazing technology where they do genotyping. They actually run the virus through their machines and look at the DNA, or in this case RNA of the virus, and determine where each of these virus cases are being connected with both within our state and across the country and world. So we sort of know what's happening. Is this local spread of the virus, or is this part of a larger outbreak, and should we be reacting differently? Characteristics of the infection, I went through some of those, but about half of the cases of Hep A are hospitalized. It's a very serious condition. It can cause liver failure, including death, and about 1 out of 100 people do die of the disease from statistics from the CDC. So far, we have had 0 deaths in Kentucky that we are attributing to hepatitis A infections, but we're very worried that may happen given the severity of many people's illnesses when they become infected with Hep A. Because this population, because of the way the illness happens, we oftentimes are unable to complete the questionnaires or the investigation at the local health departments. This is not only just true in Kentucky, this is true worldwide. And so we have a large number of people that we don't actually have the data on as far as what are the risk factors. About half the people we are able to get risk factor information, and what we've learned are that risk factors most common with Hep A is either travel to a country or somewhere else where the Hep A virus is more common. Men who have sex with men is a risk factor. Drug use, not only injection drug use, but non-injection drug use as well, since it's the fecal-oral transmission route primarily. And close contact, again, with anybody who has a known case. And there's a few medical conditions. One is a known clotting disorder called hemophilia that makes you more susceptible to getting the virus. And then this year, in 2017, homelessness has become a risk factor for Hep A transmission. We've had acute Hep A outbreaks among the homeless population, a large one in California that, as of November 10th, resulted in 649 cases, over 400 hospitalizations, and 21 deaths. This is the outbreak that our outbreak in Kentucky is linked to genetically, specifically clusters and strands that were first seen in the United States in San Diego, California. Those strands have also been seen in Michigan, where they've had over 500 cases and 20 deaths, and most recently in Utah. Utah is more similar to our outbreak. They've had, as of November 13th, 75 cases, 44 hospitalizations, and 0 deaths. So it's primarily in Salt Lake City, and that's what we're sort of being similar to in Kentucky. Our outbreak is primarily located in Louisville, Kentucky, but we've seen cases throughout the state that are genetically linked to the cases in Louisville, so we know that this is not just Jefferson County. We've seen cases in surrounding counties to Jefferson County. This is some data as of Tuesday this week, the 12th. These are numbers of cases that we have identified as a part of the outbreak. So not just the total number for the year. Total for the year, we've had 51 cases of acute Hep A for the year. But we've applied some additional criteria to say, yes, this is a case of acute Hep A, but we also believe it is associated with the outbreak, meaning that there's some type of linkage through the contact investigation or genetically linked, and that meaning that it's associated with the outbreak, and also as of cases would have needed to come in after August 1st. We are trying to go back before August 1st and do genetic testing and see if any of those cases are linked to the current outbreak, to see if there was an index case, a first person that kind of came into Kentucky. But I'm not sure that would change our response now. So as of now, we have 43 cases that are associated with this outbreak. So at Utah was 75, so we're not quite up there with Utah. Cases primarily in Jefferson County, where there's 34, and Hardin 2, Anderson, Barron, Bullitt, Hopkins, Leslie, McCracken all have 1. So you can see that there are cases in and around Louisville, but the cases that are quite a distance as well that are either linked through epidemiology or genetics to the cases that we're seeing in the outbreak in Louisville. This is data from a little bit older, but from last week. But the primary age population that we're seeing is young adults. Ages 20 to 49 is our largest number of our patients. So young adults. And the reason why is interesting. This is, I think, because of immunizations. It has been the rule from CDC and part of our core clinical service guide that children ever since the year 2006 would have been immunized to Hep A. So we're not seeing a lot of children or people who would have been, younger than their 20s as cases now. And then we're not seeing a whole lot of older people because that's when hepatitis A was more common in the United States and people are building up immunity at that time. It's the middle population where they're not immunized, they've never been around hepatitis A, and now they're getting exposed. It's a very, we're seeing that in the numbers. So it's about split evenly on male to female ratio, but as far as risk factors, as of last week, it was mostly in the homeless people, mostly having homelessness as a risk factor at 15, a few people that had interactions with the homeless, and many people, though, who have had exposures to illicit drugs, whether it's IV or non-IV drug use. And we've had a few cases among the men who have sex with men population. So the risk factors in Kentucky fit as the same as we've seen in the other outbreaks across the country and as known risk factors for Hep A. So nothing different there. But we can use that to our advantage in trying to do our outreach and immunization strategy. It's a slide. We've had genotyping done for 5 of the cases, actually, excuse me, 7 of the cases now, and they've all been the exact same case, a strand of hepatitis A as that in California and in Utah. We now have it's a little bit outdated, but a few more cases are being sent now to the CDC, and I think that's because of the response to the work that's being done at the local health department level of getting the extra blood and sending it on up for confirmatory testing, and we thank you for that work. So what we've done so far, we're partnering with Louisville Metro Department of Public Health and Wellness. They're really taking the lead in vaccination strategy and PEP outreach in Jefferson County. They have activated their incident command structure and have enhanced surveillance and supplemental questions to try to figure out what are the risk factors and specific places that the vaccine needs to go to and populations it needs to go to. We've activated the State Health Operations Center here in Frankfort, the SHOC, and we've had routine meetings between us, our state partners, the CDC, as well as conversations with the strategy being done in Utah and California and what lessons that they have learned that we've been able to incorporate into our outbreak response. So far, we have given over 700 doses of vaccine that are specifically allocated for outbreak from the CDC, mostly in Louisville. We've tried to reach out through communications to those high-risk populations and encourage anybody with high risk with risk factors to become immunized. Vaccine is, from what we've been seen so far, has been covered by most insurances, and we encourage people to consult with their local medical provider to see if they are eligible or have that vaccine. And we also know that a number of pharmacies across the state in and around Louisville as well do have available adult Hep A vaccine. The risk factors, again, MSM population, homelessness, certain medical conditions, as well as drug use, IV or non-IV. We encourage any of those people in that population to consult with their medical provider and become immunized. We've also provided written materials for local health departments, and you probably received quite a bit of that through your email traffic, and we're going to be posting that to a new website. We're working with our state communications team in developing a Hep A outbreak website. It's in its final approval status, and we'll be posting our linkages to those different documents and advisories and frequently asked questions as well. We've had communication with the hospitals. We've sent notes out to the Hospital Association and other private outpatient providers about the outbreak for increased surveillance and requesting their assistance with enhanced laboratory testing, as well as the vaccination strategy.
Dr. Ballard, excuse me, one request that we have had of hospitals and private providers, that they have identified in cases to contact their local health department.
Yes, so please be on the lookout for this. Just because of the nature of the disease being infective before symptoms, and that there is a response that can be done immediately for those people who have had close contact with the case, we're asking any providers, when they know of acute hepatitis, whether it's A, B, or C, if it's an acute case of hepatitis, it's pretty clear when you have acute hepatitis, to go ahead and start collecting that information, a one-page questionnaire, and to notify their local health department that they have a suspected case of acute hepatitis. And this is before they're going to know whether it's acute Hep A. But you may start seeing those notifications coming into your local health department. We ask you for your help to go ahead and start, if you can, investigating those cases. So we thank you very much, and thank you, Joy, for reminding me of that. Vaccination recommendations. All children are recommended to get vaccines, and it is a school entry requirement starting July 1st of 2018 that each child must have to be immunized to acute hepatitis A. And it's important because it's 6 months in between the different doses, and so they really need to get their first Hep A dose now before the end of this year. This is not a new thing at all. If you get questions, it has been the recommendation of the CDC and the state to have your Hep A vaccine ever since 2006. It's not a new thing, but it was put into regulation by our Kentucky legislature back this summer, that as a school entry requirement, just to reaffirm and to put Hep A vaccine guidelines on the same par as all the other childhood vaccine recommendations is for school entry. So you may get questions about that, but it's nothing new, and most children would have been vaccinated at this point in time, and so, but it will be something for school entry, as well as for children who may not attend public school, but would either attend private school or be part of an organized group with other children in a public school setting, even if they're homeschooled. So the high-risk individuals we went through, the MSM, the drug use, homeless, and those who travel to Hep A endemic countries, and persons with chronic liver disease is also included in that. Persons are recommended for PEP, and that is immune globulin. Immune globulin, if you haven't looked at the latest guidelines, but the CCSG was updated last month, in November, first week of November, so last month, for the new updated dosage of the immune globulin. It's now 5 times the dose that it was previously. So please take a look at that, review it with your medical director, and if you have not done so yet, try to implement that as part of your overall CCSG. That way, if a case does come in, that you'll be able to go ahead and give them the appropriate dose of immune globulin, as well as age-appropriate hepatitis A vaccine if it's indicated that they haven't been vaccinated. So with that, I think that's what I have. And Joy, do you have any questions for me that you may think that the local health department?
Would you touch on just a little bit the utilization of Twinrix?
Sure, great. So there's a few different formulations of Hep A vaccine. There's the childhood vaccine, and there's no shortage at all of childhood Hep A vaccine. And then there's a couple of adult formulations of Hep A vaccine. There is a single virus Hep A vaccine for adults that's approved, and it is available from the commercial. I don't support any particular company, but the one company that makes that is GlaxoSmithKline or GSK, and that is a private stock adult Hep A vaccine that is available, and it can be ordered for those that have private insurance. There is also that vaccine available in an outbreak situation that is available under the 317 funds from CDC, but that vaccine is in a shortage that's in the CDC possession, and so we are the whole country is under a restricted allocation. So of adult Hep A regular vaccine, we are requesting additional doses, and we have to put a justification together each time we request a dose from the CDC to be shipped, and we've done so with Louisville thus far. That's the vaccine, much of the vaccine they've been able to get out. But there is also a dose. There is a combination of adult Hep A and Hep A and Hep B together called Twinrix. Twinrix then is also indicated for that population, and there is no shortage of Twinrix. It can be ordered just fine, and it's very much indicated for people who are at risk of hepatitis B as well. So that would be primarily the IV drug use population, because of the Hep B, Hep C, and HIV are primarily transmitted through bloodborne exposure, so bloodborne pathogens and blood exposure or any other bodily fluids. And so the Twinrix with Hep A and Hep B vaccines in combo are really good for that population. So if you're operating a harm reduction syringe exchange population, or you're seeing a patient that has that risk factor, Twinrix would be potentially a really good option for them, and since there's no shortage. As well as anybody else who's not been immunized to Hep B, you certainly use Twinrix as well for that population. Hope that answers. Okay.
There aren't any questions from the field, is that correct?
Okay. No questions from?
Two things. Thank you, Dr. Ballard. Excellent presentation. I always learn something from you whenever I hear you speak.
Well.
The two questions. One, may I have your presentation so I can, if you wouldn't mind, to send that to me so I can send that out to the nurses. Yeah. And then secondly, I just wanted to mention that the Louisville Metro Health Department is working on one of their strategies is to work with the Metro Corrections Department, providing immunizations to their inmates and to their staff as well.
Yes.
And so we've so far been able to assist and help with MRC volunteers. But if that group, if we're not able to meet the Louisville Metro's need, we certainly will be sending out an email requesting help from particularly local health areas around the Louisville Metro Health Department for volunteers from local health departments. So
I can speak a little bit to that too.
Yes, sir.
So with the vaccination strategy there in Louisville, they've really put together a fantastic job of targeting those high-risk populations. And some of the strategies involve looking at where those populations come in contact with potential opportunities for vaccination. So corrections in the local jail has been an opportunity that Louisville has done outreach with and have a strategy to immunize that population, as well as their harm reduction syringe exchange program, as well as homeless shelters and other potential venues for that risk population. As you would imagine, that's a lot of vaccination to be done, and all health departments have limitations about how much they can do. And so you probably have seen some announcements come out through your different lists, but as well through our activation of the State Health Operations Center and the SHOC, there are going to be requests that will come out as well through the Web EOC program, and Joy will also communicate those as they come about. And what they've tried to do is to be as specific and narrow as possible in what their requests are. That way they can be actionable and fulfilled by any volunteers that may be able to do it through their MRC or any local health departments that have staffing available and can assist with that population. Hopefully they would assist you as well in future need and future opportunities. And so what they've looked at is specific times, specific limited number of hours, and also provide the supports. That way you wouldn't be by yourself, but you would be with a partner from Louisville that knows the area, knows what to do as well. So look for those requests to come through, and I would ask that you consider helping the neighboring county there in this time of need.
Thank you, Dr. Ballard, for your time.
Thank you.
I'll see you later today.
Absolutely.
So we'll send out Dr. Ballard's PowerPoint presentation. It has a lot of good information and data for you. Also, you can share that information with your clinical staff, your regional EPIs, so forth and so on. So next, it's my honor to introduce our new acting commissioner for the Department for Public Health. Dr. Jeffrey Howard is our acting commissioner, and we're so glad to have him here on board. And I invited him to come by this morning to say hi. He's won't be able to stay with us long. He's got many different commitments this morning, I understand. But thank you so much for your time, Dr. Howard, for coming by and saying hi to the nurses. The camera's right there for you, okay?
Thank you very much, Joy. Let me say welcome this morning, and thank you all for being on this call. Let me build upon a little bit of what Dr. Ballard had mentioned earlier. I've been incredibly impressed by the willingness to serve and help out the Jefferson County Local Health Department from the very many people I've talked to, and all those of you who are going to volunteer your time in the future to help them. We're extraordinarily appreciative. Let me thank each of you for the work you do out in your communities. I know that sometimes your job isn't easy. I know sometimes the populations you serve aren't easy to work with, but we are extraordinarily grateful. I'm very excited to be here as your Acting Commissioner of Health. I hope to continue to build on many of the great initiatives that have been moving forward when I took this office, and continuing to press forward with new initiatives that are both innovative, evidence-based, and improve the health of Kentuckians. I think that's all I have, Joy.
Okay.
Was there anything else you'd like me to talk about?
Just that you're from Eastern Kentucky.
Okay.
You're a graduate of University of Louisville.
Sure. So just a quick biographical sketch of myself. I grew up in very rural Eastern Kentucky, Harlan County. I went to Union College, which is in Knox County, for those of you familiar. Then I went to the University of Louisville School of Medicine, where I graduated with an MD, then on to the Harvard School of Public Health before taking a job here at the Department of Public Health for a brief hiatus from surgical training.
That's perfect.
Well, thank you very much.
Wouldn't want to leave that part out. Thank you for stopping by. Have a great day, Dr. Howard. All right. Next, we're going to go ahead and connect with Dr. Alyssa Briggs, who has her PhD with the University of Kentucky Department of Pediatrics. Dr. Briggs works with Dr. Hatim Omar in the Young Parents Program at the University of Kentucky, and so many of you all may be familiar with Young Parents Program and their initiatives, their one-stop shopping services that they provide for adolescents. And so Dr. Briggs is going to speak to us today about depression in adolescence and suicidality in adolescence. She's going to be joining us from her office at UK, so we're getting her connected right now.
Okay, hello. I'm on.
Hi, Dr. Briggs.
Can you hear me?
Yeah, we can. Hi, we can hear you just fine. So your PowerPoint, we're seeing your PowerPoint right now, Dr. Briggs.
Great.
Okay. All right, so I'll go ahead and turn the mic over to you, and thank you so much for joining us today.
Okay, thank you. Hi, everybody. And also, just a quick disclaimer, I'm in my office, and there is play therapy going on in the office next door on occasion, so I apologize if there's any background noise. My background is actually, I got here to the University of Kentucky by way of, at first was a special education teacher in St. Louis Public Schools. Then I went to grad school and got my PhD in school psychologist, and I practiced as a school psychologist in the suburbs of Chicago and in Lincoln County here in Kentucky. I also became licensed as a clinical psychologist and ended up here in adolescent medicine at the University of Kentucky. So I have some background in working with adolescents both in schools and in the clinical setting. Today, my goals are really just to describe depression in adolescents, help differentiate between self-harm behaviors and suicidality, and then identify components of screening that we can do with adolescents. Depression is pretty common in adolescents, and it's actually increasing as well. And it's the increase is occurring more so amongst girls than boys. So about the estimate is that about 11% of teens experience depression at some point. This is data from the Youth Risk Behavior Survey in Kentucky. This data is from the most recent Youth Risk Behavior Survey in 2017. And this is the percentage of high school students who felt sad or hopeless. And this includes sad or hopeless almost every day for more than 2 weeks in a row, and so feeling so much that way that they have stopped doing some of their usual activities. So really, this is the percentage of Kentucky high school students who are reporting a major depressive episode. And as you can see, it's about 1 in 4 students or even more across the state. And it's significantly more likely to occur in girls than boys. Well, my slide is not wanting to advance here. I think my computer has frozen. But I can, hold on 1 second. I apologize. Are there any questions so far? Can everybody still hear me? Okay, hold on 1 second while I... Can you hear me at this moment? All right, here we go. See if this works. Okay. So, and I think an important thing to note and to understand is that depression in teenagers is pretty indiscriminate. It affects, teens from every walk of life. And I put irrational here not because I don't want, I'm not saying that, teens who experience this are crazy or anything. I put that there because it affects everybody. It's not rational. There's sometimes no rhyme or reason as to why a teen is depressed. And it's important to remember that it's not just a phase for teens. A major depressive episode is relatively common in teens. But it's not just something, we can expect them to just grow out of without support or treatment. And it happens to teenagers who really, anybody looking at their life would say, they have no reason to be depressed. And I think it's also important to mention that it's not, the parent's fault too. Some parent, it happens to all teens, really no matter what their background is. So what is a major depressive episode in adolescence? It is 5 or more of the following symptoms, but it has to include the first 2, which is a depressed mood or a loss of interest in activities. And it has to be present for at least 2 weeks. So you can also see, along with that depressed mood and loss of interest, increase in appetite or a decrease in appetite. You'll usually see some changes in sleeping, either sleeping too much or having difficulty falling asleep or staying asleep. They can appear kind of hyperactive and agitated, or they can just kind of appear sluggish. They may have a loss of energy or fatigue. Feelings of worthlessness are common. Diminished ability to think or concentrate are common. And also recurrent thoughts of death can go along with this. So, sometimes in the clinic, we have teens, present to us, parents are concerned that they may have, ADHD, but, they're first becoming concerned about this maybe in middle school or high school. And it may be, and the way it's presenting in adolescence is it may be a major depressive episode. You know, you may see some increased agitation or hyperactivity and difficulty with paying attention and concentrating. So major depressive episodes, you know, they're more fleeting, and you know, they last more than 2 weeks, but they could just last a couple months at a time, and they can recur. You know, so it can last a couple months at a time. They can feel better for a period of time, and they can come back. With a persistent depressive disorder, the depressed mood or irritable mood is almost always there on most days for a year. And the criteria is for a year in teenagers or adolescents, and it's for 2 years for adults. And then along with that, you have 2 or more of, you know, the following symptoms that you would also see with a major depressive episode. And in order to have persistent depressive disorder, there can never be without symptoms for more than 2 months. This type of depressive disorder, disruptive mood dysregulation disorder, is new to the DSM-5. It is only something that you can be diagnosed with between the ages of 6 and 18. And this is really, you know, an irritable mood with just severe recurrent temper outbursts, verbal or behavioral, that are inconsistent with the developmental level. So, you know, this isn't your typical 3-year-old temper tantrum, and, you know, this isn't your typical moody adolescent behavior. It's more extreme than that. And they occur more than 3 or more times per week. And between the outbursts, the mood is persistently irritable or angry most of the day, every day. And it has to happen in 2 of 3 settings. So it can't just happen at home, or it can't just happen at school. It has to happen in 2 of 3 of these settings, homeschool or with peers. So really, you know, what is depression in adolescence? It's a lot of times invisible. You know, it's you know, sometimes adolescents with depression do act out, but a lot of times, you know, they just may be more quiet and suffering silently. And it does really affect the entire child. It affects how they feel, it affects their thinking, and it can affect their behavior or their interests. And really the main criteria, just to reiterate, is that, you know, there's a persistently sad or irritable mood. So this is kind of beyond the typical mood swings that you see in adolescence, and then a loss of ability to experience pleasure in most activities. It's not just a bad mood or, you know, feeling down or, you know, appropriate grief associated with a significant event like death or divorce or a breakup. It's more than that. But, you know, what we have a difficult time doing sometimes is differentiating between an adolescent who's experiencing depression and one who is really just experiencing a brief, you know, but maybe difficult mood swing. You know, as in adolescence, the emotional symptom in the brain, or the emotional system in the brain is really developing. And it develops before their system in the brain that kind of controls their behavior. And so, you know, really there is a biological reason for why adolescents are somewhat more moody and somewhat unpredictable in their mood and behavior. However, again, depression is more than that. It's beyond than that. And we figure, you know, we identify depression versus, you know, typical developmental moodiness and grumpiness by really, it's a change in intensity or frequency of these symptoms. They're present kind of at a more intense and frequent nature for 2 or more weeks, you know, so it's not just a bad week or a bad couple of days. The symptoms are really interfering with their social and academic functioning. You know, their grades are dropping, they're losing friends. Their behavior really can be really disruptive or seem uncontrolled. And they may have thoughts of hurting themselves or others that are ongoing. There's a couple different ways to screen for depression in adolescents. I just linked, and you guys should have a copy of the PowerPoint so you can follow these links too, to a couple of screeners that we use in our clinic. So this is the one our physicians, medical providers, and also our mental health providers use most commonly. It's just a quick checklist of 9 symptoms, and it asks how often they've experienced these symptoms in the past 2 weeks. Yeah, and it has them rated based on not at all, several days, more than half the days, and nearly every day. And then we ask, also, how much impairment they're experiencing based on this, and we also ask if they ever have thoughts about ending their life or hurting themselves. And then we score it, and the severity score gives us a sense of how significant, their symptoms are. If an adolescent on this has a score more of 15, we're pretty concerned. If they have a score more than 10, we're also concerned. And usually, those adolescents in our clinic, if they score that, they're referred for outpatient therapy. A score of like 20 on this would be very alarming, and they would need more intensive therapy. And that's the one we use most often, and that I'm most familiar with. I also have found and looked at some of the background research on this other scale, the Kutcher Adolescent Depression Scale, and it seems fine to use too. Both are free and available online. These questions are part of the informal screening that I've done, and I've come to find that they're a pretty good indicator for me of how well an adolescent is doing. The first question is there an adult in your life who you can trust and who you can go to if you're in trouble? In my experience, adolescents who say no to this question are at much higher risk of dropping out of high school, maybe experiencing a depressive episode, or seem to be at much higher risk of experiencing a depressive episode. As much as our adolescents sometimes know everything and don't feel that they need adults, but there are times when they do, and they are in trouble if they don't have an adult they can go to who they can count on. I also like to ask kind of who knows you better than anyone else, and this kind of gives me a sense of how connected adolescents are to other people. And if they don't really feel like they have anyone in their life who knows them well, then they're pretty disconnected and socially isolated, and that also places them at risk of depression. Another question I ask is, out of 7 days in a week, how many days are you happy? If an adolescent has a really hard time identifying a day when they're happy, there's a pretty good chance they're experiencing depression. And then I also like to ask about future plans, because sometimes adolescents who are experiencing depression aren't really thinking about the future. And those who are, thinking about ending their life, or thinking about hurting themselves are also really not, they may not be thinking about their future, or may not even be thinking they'll be here. So I also ask, what are their future plans? What do they want to do when they graduate high school? Any questions so far about screening for depression or identifying depression in adolescents before I move on to non-suicidal self-injury? Okay. So non-suicidal self-injury can co-occur with depression and other mental health diagnoses as well. And this is, the intentional direct injuring of the body without suicidal intent. So, self-injury has a purpose. A lot of us who don't engage in this behavior have a hard time understanding it, but for those who do, it really does serve to relieve stress. It disrupts negative emotions that they may be feeling, or sometimes when adolescents feel depressed, they also report this feeling that they don't have any feelings, that they have that they just feel kind of numb. And so sometimes self-injury serves a purpose of enabling them to feel something. And sometimes it helps them express their emotions. They may be feeling so intensely that they don't really know how to make sense of it and put it into words. And self-injury is a way to express that. Well, the way, self-injury works is it does release endorphins in the brain. And so it can become, it can become addictive. They can come to feel like they need it. I included just, a couple of quotes from adolescents who, have engaged in self-injury, and again, they've identified, that they're addicted to this experience. It makes them feel better. And I think another important thing to mention is that when people are engaged in self-injury, they don't often have the intent of killing themselves in that moment. They're actually trying to feel better. Self-injury in adolescence is also relatively common. About 15% engage in some form of self-injury. Now, and while I said, when engaging in self-injury, often they're not wanting to end their lives at that moment, adolescents who engage in self-injury are at higher risk for a suicide attempt. And at least 70% of adolescents who engage in this behavior have made at least one attempt. But, so I think, if we see an adolescent who is engaging in self-injury, we need to be concerned about their risk for suicidality. But it's not that the self-injury behavior itself is an attempt to end their life. They're just feeling so bad, that at some point it would be reasonable to expect that they may have thoughts about ending their life. This is, again, from the Youth Risk Behavior Survey. It's a percentage of Kentucky middle school students who reported engaging in self-injury, such as cutting or burning themselves on purpose, more than one or more times in the past 12 months. And in Kentucky, in our middle school students, so this is 6th through 8th grade students, this behavior is, I would consider, 13 to 20% of the population is relatively common. So about 1 in 5 8th graders are reporting engaging in this behavior. And you see this behavior more often in 8th graders than in 6th and 7th grade. So how do we identify this in adolescence? We can see frequent or unexplained bruises, scars, cuts, or burns. The most common method of self-injury is skin cutting. Often, adolescents are embarrassed by this behavior, or they don't want others to know, and so they will use clothing or bracelets or other strategies to conceal the wounds, or they'll self-injure in places that are commonly covered up by clothing. So in the vast majority of adolescents, this behavior is not attention seeking. It really is an attempt to help themselves feel better, and it's something that they know is not right and they can be ashamed about. Another thing to watch out for in order to identify this in adolescents is that they may be spending, an unusual time in the bathroom. And we know that, for some adolescents, they spend an unusual time in the bathroom anyway for other things, but it's just something we need to be aware of. If this is identified, it's important, to be direct and honest with the adolescent about what you're observing and your concerns. Listen to their perspective in a non-judgmental way. Try, and not act shocked or surprised, but, listen in a matter-of-fact way. The kind of easiest way to shut down an adolescent is for them to feel judged by you. Help them identify resources and supports that they can go to get help. It's always important, when you see this behavior, to identify and emphasize hope for how they can get better. And then also respect their privacy unless, their life is in danger. So, if the and here, we have an obligation, to let a parent know if an adolescent is engaging in behavior that places them at risk of hurting themselves. And so we kind of need to and I'll talk about this as well, do a careful assessment about, the risk that this is placing on their life. If you feel that confidentiality should be broken and a parent should be notified, I always think it's important to talk with the adolescent about how that's going to happen, why it's going to happen, and then to enable them to be part of that disclosure process, or at least be present for it. So to kind of talk with them about what they might want to say, or with the person who needs to find out, their parent or caregiver, and give them the opportunity to make that disclosure with you present. That's empowering them, and it's also helping them practice letting adults in their lives know that they're in trouble. It's important, you know, to things you don't want to do, or tell them to just stop, or have them promise you that they're not going to do it, because that's really setting them up for failure. This is a behavior that can be pretty addicting, and they aren't able to just stop it, and they may slip up again in the future, and then they may feel very bad about that. All adolescents know how they feel, and no one else understands how they feel, and they can become shut down when, you know, somebody tells them that they know how they feel, or they understand how they feel. They just want to be listened to, and have you hear how they feel, but they don't want you to say that you know how they feel. It's also, you know, for some adolescents, for a very select few, but for some, paying too much attention to the behavior can increase it. You know, I did mention earlier that for most it's not an attention-seeking behavior, but for a very, very select few, they are reinforced by the attention they get from the behavior, and too much attention to it can make it increase. And like we mentioned before, that individuals who engage in self-injury are at higher risk for a suicide attempt. So if this behavior is observed, it is important to assess for a risk of suicide. You know, you can acknowledge for them that you know that most people who engage in this behavior aren't trying to die, but you also want to kind of understand if they're having any thoughts about ending their life. If this behavior is observed in adolescents who do indicate they have thoughts about ending their life, they have other comorbid mental health concerns, they've experienced abuse, trauma, substance use, or an eating disorder, or they have severe tissue damage or infection, they are at higher risk for ending their life. Any questions before I move on to suicidality? I just kind of want to pause and take a moment here or there, because I tend to talk kind of fast.
Okay.
Huh?
No questions at this time.
Okay, thanks. Okay, so for suicide in adolescence, it is the second leading cause of death among people ages 10 to 24. My background is a school psychologist, and our national organization conducted a survey of school psychologists in 2008, and 33 of them, so 1 in 3 of them, indicated that a student in their school had died by suicide. So it is something to be aware of, and something to watch out for in adolescence. In Kentucky, about 15 to 22% of middle school students reported they had thought about killing themselves. This was a more common report in girls than boys, more common in 8th grade than in other grades. And in high school students, the numbers are somewhat lower, but not much. And again, about 12 to about 19% of high school students are reporting that they have seriously thought about ending their lives. Again, this is more common in females than males. This is also more common in the 11th grade. And if you talk to adolescents, almost all of them will tell you that 11th grade or junior year is the most stressful year. They're worrying about the ACT, they're worried about applying to colleges, they're seeing, their high school career coming to their end, thinking about their future. but they're still having to take a lot of those stressful required classes. They haven't, you know, hit the relaxed senior year mode yet. So it doesn't surprise me that more 11th graders are reporting this and 12th graders. We've also seen, you know, in some of this data, higher numbers in 8th graders, and my speculation is that that coincides with the data we see regarding bullying, that bullying also tends to be relatively higher into 7th grade and 8th grade. And I think, you know, for those of us who experience middle school, or those of us who are around middle schoolers, you know, that's pretty consistent with, you know, our experience, and my experience working with adolescents. And then, you know, so we are concerned when adolescents say they've considered ending their life. We're more concerned when they've thought about how they would do it. And again, about 10 to 14% of middle school students indicated they've thought about how they would end their lives. Again, this is more common in girls, more common in 8th graders. And in high school students, about 12 to 14% have thought about how they would end their lives in the past 12 months. This is most common in girls. For those who have attempted to end their lives, that's about 4 to 8% in middle school students, more common with 8th graders, more common with girls. And not all of middle school students and high school students who attempt to end their lives have needed medical attention or even told anybody. You know, so this data is, you know, what the students are reporting themselves. I've worked with several adolescents who have, you know, made what they considered an attempt to end their life, but it didn't result in them needing medical attention. So nobody knew. So it's important, you know, I think, to ask adolescents if they have ever made an attempt to end their lives, because it's not always safe to assume that somebody would know if that's happened already. And in high school students, the number of students who reported, you know, having made an attempt at ending their life was about 4 to 10%, more common in females. And actually more common in 10th graders than 12th graders. And this is, you know, based on statistical analysis. And then more common in black students than white students. And this data is not available, or couldn't find it for middle school students, but for high school students, this is the percentage who have made a suicide attempt that resulted in an injury, or poisoning or overdose that had to be treated medically. And this is about, you know, 1 to 4%. And when I think about this, you know, sometimes in, you know, in terms of real numbers, you know, so if I, you know, worked in a high school, you know, with 1,000 students, really, you know, a good handful of students will have had, you know, a serious suicide attempt, and I think that's quite concerning. In Kentucky, in 2015, about 23 children died by suicide. Most were between the ages of 15 and 17 years, and this represents actually a big increase from 2014. And the most common means by which kids die of suicide is a firearm, and then followed by strangulation. And so I think, you know, a really critical question to ask as well in working with adolescents is if they have access to firearms in the home, and if so, how they are stored. So, you know, we have our Dr. Omar, our clinic always tells the story of a patient he worked with who came home from school that day upset, wanted to end his life, went looking for a gun in the home, but the gun was locked up separately from the ammunition. So he looked and was, you know, able to figure out how to unlock the gun. Then he went to go look for the ammunition and was eventually able to figure out how to get access to the ammunition. but by the time he was able to get both, he rethought wanting to end his life and didn't go through with it. So if that child had been able to come home and get a loaded gun right away, he may be dead. But having the gun and the ammunition locked up separately saved his life. Adolescents who are at the highest risk for suicide are those actually who've been discharged for psychiatric hospitalization. And I don't think that's necessarily because the hospitalization did something, to make the kid worse. It's just that, they went into the hospitalization in a high-risk situation. The doctors and, nurses and mental health professionals in that inpatient unit, were able to stabilize the child enough for discharge, but that doesn't mean that they're okay. They still need a lot of support once they leave that hospitalization. And the level of risk after hospitalization decreases. But again, if there's ever been a point in the child's life, where they've needed to be hospitalized due to their risk for harming themselves, they are a kid who's more at risk for ending their lives. And so we should, pay attention to whether or not a child has ever had a psychiatric hospitalization. And also, whether or not they've made a prior attempt. That makes a future attempt more likely. Substance abuse makes an attempt at ending someone's life more likely, partly because of the disruption in mood substance abuse causes, and also, substance abusing and using substances makes people more impulsive. Also, having a firearm in the home increases a child's risk of dying by suicide by 5 times. And so, whether or not a kid has a firearm in the home is something I often ask. And I often ask how it's stored, and I often recommend, that the gun be stored separately from the ammunition and locked up. Other risk factors that put a child at greater risk for death by suicide are, if they've experienced depression or victimization or bullying in any way. Also, at-risk groups include kids who are using with, mental health diagnoses, adolescents who are using substances, and then, children with a history of trauma. Runaway or homeless youth are at risk, but often, children who are adolescents who run away, who are homeless, are often, put out of the home, maybe because they're lesbian, gay, bisexual, or transgender, or maybe because of their substance abusing or other concerning behavior. And kids who run away are often running away from difficult home environments, which can put them at higher risk as well. And then, the frequent flyers I have in there are at higher risk. So those are the frequent flyers are kids who we often see in the discipline office. So, very few kids, have true conduct disorder. Most kids who are acting out are acting out due to some sort of stress, and that could be an underlying mental illness. Family history of suicide also, is a risk factor. Of course, feelings of hopelessness that goes along with depression. I often worry about the kids I work with who have a diagnosis of depression and a history of aggressive behavior or impulsive behavior. So my kids, with ADHD and depression, I worry about because they're not always going to think through their actions, or kids who are aggressive with others could also become aggressive against themselves. Having a suicide occur, in the community or in the school also places an adolescent at greater risk of suicide. Suicide contagion does happen. It actually happened at my college, my sophomore year towards finals week. My college actually ended up shutting down before finals, in order to stop the contagion from happening on campus. You know, in our rural counties, you know, there are sometimes barriers to accessing mental health treatment, and that places kids at risk. There are some attempts to ameliorate those barriers by mental health professionals going into schools and seeing students at the schools, but there are still many, many students out there who need help who don't get it. Experience any loss or any death in the family of a friend can place a kid at greater risk of thinking about ending their own life. Physical illness, I have, you know, some patients I work with who have, you know, diabetes or arthritis, and, you know, they become frustrated with coping with those conditions, and they sometimes have thoughts about ending their life. I also have a kiddo who's experiencing chronic pain and has thoughts about ending their life in order to escape the pain. So we need to, you know, be concerned about those individuals as well. Of course, easy access to lethal means is a huge risk factor, and, you know, that's because the nature of adolescents are that they are rather impulsive, and that's because they're, you know, like I mentioned before, their emotional system is developing and maturing, and the prefrontal cortex, the part of the brain that helps them regulate their emotions and think through their behaviors, doesn't mature until a little later, almost age 25. You know, so that if they have easy access to something that can harm them, you know, they may not do a great job of thinking through, you know, whether or not they should use that. And of course, an unwillingness to seek help, you know, puts a kid at risk because they're not getting the help that they need. So what should we look for that can help prevent suicide in adolescence? And that is connectedness with others. That's why I asked the question, you know, who knows you the best? Is there an adult you can go to who you trust? Contact with caregivers is important, and supervision by caregivers is important. Even if it's also important, you know, for adolescents to hear that, you know, caregivers are open to talk, even if the adolescent doesn't want to talk with them. They seem to benefit from just hearing, you know, that somebody is open and available to them. Availability of care is a protective factor, so easy access to medical and mental health care is important. Their ability to cope, of course, is a protective factor, and, you know, we can help, or schools can help strengthen that ability by teaching just social emotional learning in schools. That occurs in some schools. You know, they're just often, you know, quick lessons that are done during a homeroom period on self-regulation skills, and that can really be a protective factor as well. And then helping an adolescent develop problem-solving and conflict resolution skills can help them too. And again, what helps a teen do well, what helps them be resilient, that is having a caring adult in their life, a safe place to interact with that adult, and then something useful to do, or a hobby. You know, and I didn't include this earlier, but I do think another important question to ask is, you know, what extracurricular activities are they involved in? What do they do for fun? And so if we look at the Youth Risk Behavior Survey again, you know, this is the percentage of middle school students who don't feel that they have an adult in their life that they can trust and talk to. And so these, you know, so that ranges from about 9 to 13% of students. And then these are the percent of students who reported that their parents or other adults in their family, middle school students, most of the time ask where they are going. So adult monitoring and supervision is an important protective factor as well, both in preventing self-harm and suicide and substance abuse and use. Any questions so far before I talk just a little bit more about screening? Okay. So how do we identify suicidality in adolescents, and how do we figure out whether or not we should be concerned, and then how do we respond? When we're asking about whether or not they've thought about ending their life, we want to pay close attention to how often those thoughts are occurring, how intense they are, how often those thoughts last, and then whether they have any specific ideas about how they would like to end their life. If they have specific ideas, it's important to assess if those means are available. If a child tells me that they have some ideas about how they'd want to end their life and those means are available, of course the parent is notified and advised to make those means unavailable, and I recommend further evaluation in the emergency department for hospitalization. And then we also want to pay attention to any active behaviors, any preparation or rehearsal. And I think, this is, so for example, that may be, getting the gun out and putting it to their head. They're not intending to pull the trigger at the moment, but they're preparing it and for that ultimate behavior. I think another reason why kids who engage in self-injury are more at risk for suicide is, they may not be intending to end their lives in the moment when they're cutting themselves, but they are rehearsing a potential behavior that could end their life. So, when I screen an adolescent, I don't, it doesn't hurt or make a kid more at risk to ask them directly if they're having these thoughts. But I don't say things like, are you suicidal? Because, a lot of adolescents will look at you cross-eyed when you ask them that. But I do try and normalize, their feelings and then their thoughts by asking, have you ever been so sad or angry or upset that you've thought about hurting yourself? And have you ever thought of, and I kind of ask, that first, because that kind of, I'm not asking, directly about them ending their life right off the bat, but I'm kind of warming them up to that question. And I ask them, have you ever thought about ending your life? Then if they say yes, and have you ever thought about how you would do it? Have you ever tried? Do you have a plan right now? And then do you have access to firearms, or, if they've mentioned other means, do you have access to that? And so really, the screening for suicidality doesn't have to take all that long. Really, I think if just these 6 questions are asked, you could have a good sense of how at risk an adolescent is, but you could go further and ask, how often are you having these thoughts? For example, when you have these thoughts, how are you feeling? How long does this last? Sometimes other questions I ask are, when you're having these thoughts, what do you do? Like, do you reach out and tell a friend? Do do they try and get help? Do they try and implement some coping skill? So that also, gives me a sense of, that are they having these thoughts and trying to resolve them, or are they having these thoughts and getting stuck in them? Of course, I would send, a child or, advise their parent to take them to an emergency department for a further evaluation if they are at high risk. I know, also, for kids who aren't close, to a place that kind of has a good understanding for how to evaluate kids for suicidality, some places do have mobile assessment teams that will come out. Like I know the Ridge here in Lexington has that. The Ridge can also do further assessment via webcam. Similarly to self-injury, I try to build hope and resilience by talking, I talk through my concern with the kids, offer hope for how things, can be better, help empower them to kind of talk with an important adult in their life by helping them through that process of breaking confidentiality to let somebody know they are at risk of harm. If I send, a child, for further evaluation or recommend, thinking about hospitalization, I still don't let them, leave without having some resources or some ideas for some coping skills that they can use. So one thing I do is, when I got this idea at a training I went to, I have just little small squares of paper or index cards in my office, and I have them maybe write down a number or a person they would agree to contact if they're having these thoughts, and maybe a skill that they can use to, or a couple skills or coping skills they can use to help themselves. So, if they like to, a lot of adolescents will indicate, well, I feel better when I draw, or listening to music helps me feel better. If they can't identify anything, you can Google, I think there's just coping skills for depressed mood, or coping skills for suicidality, and there's a website that has a list of 154 different coping skills that people can use. So I have that printed out in my office, and I'll have them just look at that and circle a couple, and then we'll put that on a card. I create a safety plan, so that includes, helping them identify, when the thoughts occur, what their triggers are for these thoughts, who they can contact when they're having these thoughts for help, and coping skills that they can use. And just like, for self-injury, where we don't say, oh, just, promise not to do it. The same thing for suicidality. We don't create no suicide contracts because those don't typically work. And so what we do instead, again, is we create this safety plan. I did include in the PowerPoint some resources that can be given to adolescents, or that can be used. One that I've had teenagers respond to positively is to write "Love on Her Arms," and that provides some resources that seem to speak to adolescents who are struggling with depression, self-injury, and suicidality. Another one that I've had some adolescents find on their own and mention to me that they like is the Butterfly Project. I did not include that on there, but if you just Google Butterfly Project, it comes up. And 1-800-DOE-CUT has information on self-injury, and it's also a hotline adolescents can call. And I believe the 1-800-273 talk line is a crisis hotline, but I believe it also has, I'm just double checking, I think it has a text function now too, which most adolescents prefer. And very few, usually, that's the National Suicide Prevention Lifeline. It's the same thing as 1-800-273-TALK. So if you go to the suicidepreventionlifeline.org, there's an online chat, and adolescents can use the online chat to access more help. I think, most teenagers don't pick up the phone and call people. They text, they get on their phone that way. So a lot of times, they'll be more, I find they're more open to doing like a chat or a text crisis line than an actual phone one that they call. I've maybe, had 1 or 2 adolescents actually call a crisis line that I've worked with. It's really the text and chat function that's more helpful, or some of these other web-based resources. Okay, that is all I have. Are there any questions overall that I can answer?
Thank you, Dr. Briggs. We do have a couple of questions. One, okay, the first one is, are we finding this is correlated to social media use? And I think yeah, it is correlated, I think. I don't think correlation equals causation, necessarily, but I do think it's correlated. And I also think that's why we see a sharper increase in girls than boys over the past years, because girls are also more likely to be engaged in social media. And, social media, when online bullying is occurring or negative things are going around in social media, it can be really oppressive. Before social media existed, like when I was in high school, if you were bullied at school, when you left school, you could have a break from it. But now it continues online, and it just follows you everywhere, and it feels like there's no escape. Yeah. Thank you. The second question is, what are your thoughts on adolescents and the healthy use of social media, specifically in regards to kind of help parents know what those boundaries may be.
Yeah. So what I recommend, and adolescents usually don't like these recommendations, but for social media use, I recommend an open door policy. So if homework's being done on the computer, it be done in a public area, or the expectation is that if it's being done in the room, that an adult could walk in at any time. I think that helps kids stay safe from negative social media use, but it also helps kids stay safe from human trafficking or being sexually abused online. I've had some adolescents. I've had that there's these online chats you can get into, webcam chats with random strangers, and I've had some adolescents get in trouble and be sexually abused online via that way. So I think with the internet and adolescence, an open door policy is important. I think it's important to have the expectation that every once in a while your parent can get on and look at your Facebook page or your Instagram page and see what's being posted. I also recommend turning in the phone before bed, or if there's a way to automatically shut off the Wi-Fi or automatically shut off the data, at a certain time, to do that. The adolescents need to get sleep. If they don't get sleep, you see an increase in mood disorders. So I think that's one reason to have, the phone or the, media taken away at a certain time. And also, I don't think anything good ever happens after midnight. So,
exactly.
Anywhere. So I think it's, best for adolescents not to have access to that overnight.
Are there any other questions from the field for Dr. Briggs? Thank you, Dr. Briggs. It was an excellent presentation and very timely and relevant for local health department nurses. After about the 6th grade physical point in an adolescent health care continuum, we don't really see in local health department clinics adolescents as much, except for if they present for perhaps family planning or STD services, or perhaps maybe some immunization services. But absolutely, local health departments either provide school health services with their local school partners, or they are partners with the Kentucky Department of Education, where they are familiar with school health services and resources within the communities. And so if you all from the local health departments who have listened to Dr. Briggs, heard her presentation today, and have her PowerPoint presentation, please feel free to share this information with your schools or your school health nurses and your clinic staff as well, who may provide care for direct clinical services for adolescents.
Yeah, and you're also welcome to, you can share my email with them too. I didn't include it on the PowerPoint, but if you ever have any questions, you're always welcome to email me.
That's wonderful. That's great. Thank you so much for your time and your willingness to speak to public health nurses today, Dr. Briggs. And we appreciate your time and your expertise and your willingness to just spend a little bit of time with us today.
No problem. Take care.
You too. Bye-bye.
Bye.
So, okay. Thank you. So our next presenter is Vivian Lasley-Bibbs. Vivian is our director of the Office of Health Equity here at the Department for Public Health, and she's also my next-door neighbor, where our offices share a wall. So we're so happy to have Vivian here today. Many of you all may know Vivian and her outreach and her area of knowledge and expertise regarding health equity and reducing health disparities within Kentucky and health care. And so Vivian was recently trained. She's a certified trainer now, in the Bridges to Health and Healthcare curriculum. So you all may have heard of Bridges Out of Poverty. This is kind of the sister correlated training to health and healthcare. So she'll probably get into that just a little bit, but I wanted to take advantage of my next door neighbor, and since she is a new trainer, give her the opportunity to share with you all this new curriculum and see how this information may be applicable in your daily practice within your local health department. So thank you, Vivian, for being with us today. And I'll turn over the camera and the mic to you. So the camera's right here.
Oh, right there. Okay.
Yep. Okay.
All right. And I'm going to sit, if that's okay. Can you still see me if I sit?
We'll get you down here.
All right. So I want to thank Joy for allowing me to share this new training opportunity, the Bridges into Health, with her nursing staff and folks at the local health department, etc. So I'm pleased to do that today. I will preface this by saying this is just like Bridges Out of Poverty, where it can be an all-day training. I'm going to give you an all-day training in an hour. So we're going to be flying through some things, and you'll see where it's going to say case scenarios and exercises. Those are if I had you for a whole day captured, and we would actually walk through Bridges into Health just like you do Bridges Out of Poverty. And if you haven't had that, I encourage you to take Bridges Out of Poverty and then take Bridges into Health and Healthcare, because it uses the Bridges Out of Poverty lens in a specific system. So, all right, so I'd like to get started and just tell you the 4 areas that we're going to talk about today as it relates to Bridges into Health is looking at the individual, the institution, the community in which you are surrounded, and potential policy that may impact how folks are served and healthcare delivery is offered. We're going to examine the business case for using our work to improve our patient, client, and provider relationship, and also the financial impact it can have on the institution. Because if you get patients to come and continue to come, then that's a win-win for everyone. All right, so this is a busy slide, but what I want you to see is that there's these are the resources that can build this model for bridging healthcare with communities. So you'll see on the left side it talks about community approach, and those were the 3 things I mentioned: the individual, the institution, and the community. On the right side, we kind of have that basis for Bridges Out of Poverty. What causes poverty? Usually it's an individual behavior, it's people's physical conditions, the physical and built environment, their community conditions. Exploitation, meaning those that have power and those that don't. Political and economic structures that have been in place, policies that have been in place, those institutional and structural barriers. And then down at the bottom you'll see 11 required resources to make all of this work. It's financial, emotional, cognitive, spiritual, physical, all of those things that we talk about in Bridges Out of Poverty. And then if you look at the circle, in order to have a sustainable community, I think we all kind of agree everybody needs to be at that table. Employers, people in education, the criminal justice system, businesses, community partners, and of course the healthcare community. All of this is required for optimal health and wellness of any given community. So today we're going to talk about policy, how it affects the individual, the institution, and community using a Bridges lens. If I go too fast, don't worry, I hear you have these slides. So I'm going to be moving kind of fast because I have a lot of slides and I have a lot of good information I want you to get. So if I go too fast, is there a way for them to acknowledge that I need to slow down? Please do so. If I get on a roll and you feel like I'm losing you, then just acknowledge that I need to slow down or go back to a specific slide. And there's always an opportunity for questions at the end. So when we think about economic class and health, we can't help but think about poverty, because poverty is our driver for disparate health outcomes. It's one of those drivers is the SES picture. So when we think about an individual, we're talking about the personal or professional mission of your institution, how it responds to policy, how the impact of economic and cultural diversity of health and disparate populations impact that community, and how policy can erode human capital. Because if a policy is in place that disengages or makes one population disadvantaged over the other, then that's not optimal community wellness. So here was a learning exercise, and we're not going to do the exercise, but I want you to think of the 3 questions as you think about individual, institution, and community. Which lens do you hear mostly from? Do you hear mostly from your individual lens? Do you hear from a community lens, or from your institution? And are you open to viewing health through all 3? Usually healthcare communities are very rigid, and they view health and wellness through one dimension. They don't think about the other 2, right? They don't think about the community or the individual. So identify your favorite lens and think about how you could be open to hearing all 3. So think about 3 ways you can improve your skills in working with people from different social classes. Ask yourself whether you feel competent in doing that. What are 3 ways you can improve your institution's relationship with the community through policy, through procedures, and how they can engage clients and patients of more diverse backgrounds? And what are 3 ways they can improve community systems or environments that can have a greater impact on the health and wellness of that community? And what follow-up does your agency or organization need to do to accomplish that? And you won't solve it in a day. You won't solve it after taking this class or this training. But it is something for your institution and your agency and you to think about. So when we start talking about bridges into healthcare, we have to start talking about which model or which framework we're going to use. And I like to think of bridges as a framework. It's not a program. It's not a canned packaged program that I can give to you and you say, do Bridges Out of Poverty and all your problems will be solved. It's strictly a lens on how you view people and communities. And the lens helps you define an economic class or an environment. So that middle model includes, if you know anything about Bridges Out of Poverty, includes poverty, how they view and prioritize their situation, how the middle class uses their lens to prioritize, and how the wealthy. And interventions don't work unless you know something about how they view their world, which lens they're looking through. So Bridges Out of Poverty kind of helps you look at that, and Bridges into Health helps you know that, okay, looking at a healthcare system, using those different lenses, this is the impact and what happens. So I kind of think of searching for the Holy Grail. I'm an Indiana Jones fan. If you're not, that's where the Holy Grail concept comes from. The search for the Holy Grail of quality. So this is just some numbers. This slide, they really need to update this from 2012, but this was the last NIH study looking at where we rank as it relates to health. So compared to 17 what we consider high-income countries, where do you think we are? Yes, we're at the bottom for at least 9 of these indicators. Infant mortality, heart and lung disease, sexually transmitted diseases, adolescent pregnancies, injuries, homicides, and disability rates. And obesity-related illnesses such as diabetes is the #1 cost driver in the United States. $245 billion spent in 2012. So what do you think that number is here as we enter 2018? Right. And I feel very comfortable in saying I'm sure that number has increased. So what do we know? We know that the cost of health and health care, it's increasing every year. The majority of baby boomers will be on Medicare by 2020. Health is directly related to your education and socioeconomic status. And lack of resources reduces individual, institutional, and community collective efficacy. And we'll talk about that last one as we go through. So as we go about our daily lives, whether it's public health, professional health care delivery person, whether it's an FQHC or a hospital, we know that it's not about the lack of effort that's going out of these institutions, or the lack of effort as you as a nurse or a healthcare provider, or the energy that you're giving daily. We know we do 110% put in long hours. What we know is that it's driven by money, by policy, by new research that's coming out with new innovative techniques. We know it's coming from sophisticated diagnostics, sophisticated treatments. Every time I look up some kind of advanced technology system for diagnostics and for treatment and professional training. We're ever learning and ever evolving as healthcare providers. So this is the triple aim that usually healthcare people like to think about. We want to improve the experience of the person walking through our doors. We want to improve the health of the population of the community in which we sit. And we want to improve the affordability while reducing cost. I think we can all agree on the triple aim. But how do you really do that when we're going to a value-based outcome continuum where it used to be a fee-for-service? And if you're like me, I came into the healthcare professional field when it was still fee-for-service, and you got more things you did, and the more tests you ran, and the more things that you could put on that plate, you got paid for doing them, right? There was a reimbursement for all of those things. Now we're kind of looking and saying, maybe we need to step back and do more of a value-based outcome model where we spend more time with the patient and we help connect them to resources and services that are going to keep them healthy overall and not just look at that patient as one entity. Oh, they're diabetic. Oh, they have heart disease. Oh, there's all those other things that have to go into consideration for that person that walks through with diabetes. So you'll see in this slide, it's very busy, but I want you to understand that this value-based model looks like, if you look on the right side, you'll see the patient engagement in longitudinal care. You see things that now we're seeing with patient navigation, with community health workers, with the medical home model, with palliative and primary care. All of these things are the bigger piece of the pie now as we increase access to at-risk populations, right? So we're decreasing that fee-for-service and trying to do more with value-based outcome using the right side of this circle. And looking at the left side as we look at cost and clinical procedures and things that ACOs are doing to help patient care. So, time for a new prescription. And what does that look like? This is a very busy slide, so I have broken each one of those top area topics down in the slides to follow. So if you'll see across the top, it defines all of those research areas and it gives an example underneath for each one. And I'm looking, so let's talk about access for a second. So if you think of access, that's the ability to enter or engage in a healthcare through a provider, through a healthcare system or another resource. And we think about all of those things that make access possible, right? Whether you have insurance, whether you have a copay, whether you have a way to get to that appointment, what's the process involved in making that appointment? Do you have to wait 3 months to get an appointment? What are the policies related to that institution regarding your health care? And what contact information is needed and what medication types need to be considered for me to be engaged into your system? And think about availability. I don't have to read all those for you all. You know the conditions and time frames in which health care can be received or allowed. All of those things affect availability. Look at cost. Pricing of over-the-counter meds versus prescription meds, the billing process, the new coding that's come out, paperwork cost, the different payer sources, all of those things. Look at quality, the extent to which services are provided actually improve the health outcome. So what about wraparound services? Everything that's needed to keep that patient healthy. And think about the fragmentation sometimes of the delivery of care and the knowledge and experience of the provider. Right? Standards of practice, the knowledge of the healthcare system. Are you going to a place where you know you're going to get the best quality of care, or are you going to a facility just because your payer says you have to go there, or it's in your neighborhood? You don't have any other options. Those affect quality of care. And then there's efficacy, right? That's the capacity to really produce the desired optimal health outcome you want at all 3 levels, right? And you have to think about the community resources, the individual resources. You have to think of the diversity and makeup of your community, whether there's social cohesion, and we'll talk about social capital later, whether there's patient compliance, because people have to question their efficacy if we're seeing the same person in the emergency room every week. And the readmits. Are we being efficacious if we see the same type of person being readmitted into our facility? And then we've got to be open to change models, right? Things that can work differently to be more effective. And all of that involves communication. How do we communicate with our patients? How do we communicate with our community? There are those hidden rules. things that, those little nuggets that you need to know when you go into communities that that will help you build trust and relationships and knowledge. If you just take a minute to maybe learn some of those hidden rules. And all the time that I think hurts us is using a formal register all the time. We have to be so proper and medical terminology and use these big words to show that we've learned our profession. Sometimes casual register is okay. Casual register talking to a person to get them to understand how to take their medication, to hear their story, to let you tell them your story and you hear their story. Thinking of the impact on poverty, on how people plan and think, and how they prioritize. Remember those mental models, those poverty, there's middle class and wealth. Those are all important in communicating to folks. And then nonverbal, those nonverbal, your body language, how you relate to people. And then your role of your voice in changing things. Listen to that person talk to you. What is their voice saying to you about maybe a change that's needed in a policy or procedure or the way that they receive their care? So how do we bridge the gap? I have a YouTube link in here, but I didn't know if we would be able to do it. So we don't have to. You can go to this YouTube link, and there's about a 8-minute presentation, 7 or 8 minute presentation on how you actually take all of those pieces together and you ask the questions who, when, why, where, okay, for your community. It's really very cute. I suggest you look at it. It doesn't take very long, but it kind of ties everything else that we've talked about for the first 10, 15 minutes into this one little YouTube clip. So when we talk about human interactions, how a patient's perceived, how the clinic staff perceive that person, how the healthcare institution influences the treatment of that patient, and how that patient perceives the staff. Are they equally powerful? Or do they feel like there's a less of me and more of them type hierarchy? So sometimes patients and providers can feel like they're in a rut. No matter how hard they try, they get the same results. Everybody feels it, even if you're the thinker and a consultant. You feel like we're doing the same thing. We're seeing Bill back in here every week, every month, and I'm giving him the same lecture. We're going through the same conversation and getting the same result. How many of us have felt that way? I think we all have at some point. But I think we need to figure out, how do you escape the rut, right? How do we get past that? How do we get Bill out of that rut? And how do we get ourselves out of that rut? So when we think about the self, the institutional and community models, they're places that we can fail along the way. So the Bridges lens helps you think about 3 things to kind of keep us on track. Could this be a failure of Bill and I not knowing what to do in his case? Could it be a lack of power because of some rule or policy or some procedure that's keep preventing Bill and I from having a better relationship with his compliance and his recidivism to the ER? Is there something that way? Could it be a failure of not knowing how, in the absence of a structure or some kind of surrounding support system, to kind of allow for a creative way to keep Bill out of the ER, on his medication, and I see him less in the clinic? So think again, the Bridges model is not a program, but it's how we think about things, right? How we organize things. So people and organizations use Bridges to develop strategies. We improve relationships at the individual level, organizational level, and community level, and you're going to hear me say that a lot. But it's emphasized a lot of Bridges into health because all 3 are needed. So Bridges helps us think about preventing poverty, alleviate suffering for the people that we interact with, support people that are in transition, okay, either in or out of care, and then ways that we can just eliminate poverty altogether. And that's the hard one, right? But we want to make things easier for folks that are in poverty. So the definition of poverty, it's not necessarily linked to money. So I think when people think of poverty, they think of a dollar amount. Poverty is really just the extent to which an individual has access to resources, right? That's poverty. So how do we get started to think about poverty as a lens to look through? So I want you to think of Bridges and using the Bridges lens not as something extra that you have to do, but it becomes habit with you. It becomes something that you internalize, and you think that way all the time. It just becomes you, right? So I want you to think about who needs to be at the table, who you need to have this discussion with, how you can sustain this how you can sell it to your institution, right? How you can make bridges and using that lens part of your medical institution, part of taking the mental home model to the next level. That means collaborating with people at the grassroots level, having people at your table that maybe aren't necessarily always at your table. Think outside of your healthcare box, your healthcare institution box. So another lens. These are two friends of mine who did the forward for Bridges into Health. So Bridges helps the customer service aspect. From a clinical practice, you're focused on the illness, that lab result, that test result, and you look just at the person. The Bridge lens allows you to understand why, as a provider, you need to maximize that opportunity when that patient's in front of you. We take more insurances, so we're seeing more and more people who come from different cultural backgrounds with different hidden rules, different communities, different populations. So the Bridges lens and its impact on a stable environment. So if you think of most healthcare entities, they use stable environment rules to operate, right? Meaning they have these rules in place because the efficiency and efficacy of that healthcare institution demands it, right? So the clients and patients that come through the doors are based on the knowledge and use of those rules that the healthcare system has in place, right? There are assumptions that that healthcare system makes. So interventions need to be created around the assumptions of the hidden rules sometimes and not the rules of that institution. So how do mental models of class affect health status? You saw all of those 5 things that we talked about. All of those 5 things affect health. So this is a busy slide as well. These are the 9 resources or 8 resources that need to be in place to have optimal health and wellness for people in your community. We need to think about the mental, whether our clients can read, write, compute, the financial, whether their shelter and basic needs are taken care of. What about their mental health? What about their spiritual health? What about their physical health, their active daily living things that they need to do? Their support systems, their social and bridging capital, and that's going to be important down the line, and we'll talk about that in a minute. And then the unspoken cues that they have within their groups. And then there's that formal register. Okay? Do they always use the language that's in textbooks, letters, policy manuals, and medicine? So let's talk about hidden rules for a second. Hidden rules are those unspoken cues or the habit of a certain population that they learn collectively. And they're deep-rooted in those communities. And they can be learned in new environments too. And they're critical sometimes for transitioning from poverty to middle class to wealth. And social capital impacts those relationships, and they also impact health behaviors, hidden rules do. So can you think of a hidden rule? Let's think of a hidden rule. What would be a hidden rule in some of our driving forces? For poverty, let's think of where we are. The driving force for poverty is you're thinking about just getting through the day. That's surviving, that's building relationships, and that's having some form of entertainment. That's your priority. Middle class, the middle class is constantly working, constantly achieving that. We want that security. We got to have it. And then wealth, it's all about connections because you already have the finance. You're worried about your political and social standing within a society. So those are the things we need to remember. But people in poverty, think about how they think about food. It's all about, do you have enough? In middle class, we're worried about, do you like it? Did I prepare it to your liking? And in wealth, it's all about the presentation. Have you ever been in a restaurant and you come back, it comes to your table, you say, oh, it's presented so well. That's the wealth. And then we think about destiny. With poverty, we can't believe it. There's nothing we can do. It's just fate. Middle class believes I've got a choice. I can change it if I make the right choice. And the wealth, it's noblesse, and I'm not French, so noblesse oblige, is that how you say it? Anyway, it's going to be because of who I am. Power, same way. People in poverty don't think they have any power at all. People in middle class respect it, respond to it, related on position. And people in wealth, they have power and expertise in connecting people and being stable in their wealth and being able to influence power and the direction of that power. So I want you to think about something. Have you seen a hidden rule influence your capacity to have a positive or negative effect on a patient? Have you seen a hidden rule have a negative or positive case? I'm going to give you an example, and I want to know how I'm doing on time if I can read this little case scenario. Oh, okay. So I'm going to read a little case scenario to you, and then I'm going to ask you a question. I just want you to think about it as we go through this scenario. So we have Bill Johnson. We'll call him Bill. And Bill comes to the emergency room with elevated blood pressure, high glucose level, and a stasis ulcer on his heel of his foot. When the ER staff do the history and physical assessment, they admit Bill because he hasn't been taking his meds. Notation on the chart, this patient is non-compliant. He was admitted to a floor. He was assigned to an attending physician. Interns and residents came in, reviewed the protocols, talked to Bill. Billing clerks came in and told him his financial responsibility, and told him how to make sure the coding was correct to maximize the highest amount of payment for that facility. So Bill was well known to the nursing staff. The attending physician, however, had not seen Bill. So Bill, he asked Bill the same questions and could tell that Bill was a little apprehensive in talking to him and telling him why he was in the facility today. The wound care team came in, took care of his ulcer. By now he was utilizing all the nurses on the floor. They were looking at his chart. They discharged him to the clinic. They ran all the usual tests, stabilized Bill, sent him home. As predicted, he reconnected with the nurse practitioner at his clinic who he felt comfortable talking with, and not the folks at the hospital, because they addressed him by name. And he didn't like going to the nutrition and then the diabetes educator because he knew that stuff, but he went because it was policy and they said he needed to go. So, what can we say about Bill? What do we think about Bill? How could we have interacted with Bill better? And we know Bill had a disparity because he's diabetic, okay? And we can think about diabetes in Kentucky. There are certain populations in Kentucky where there's definitely a disparity with diabetes, all right? So aside from knowing a lot of information about Bill, why was Bill able to manipulate the new staff in the hospital and him thinking that he was non-compliant? And he knew the system. He knew what was going to happen when he got out. He was going to go back to that same nurse or nurse practitioner that had taken care of him. And it was going to be a non-compliant issue. So finally the nurse asked Bill, why aren't you taking your medication? Here was Bill's response. It costs too much. I can't afford it. Had anyone asked Bill that before? You wonder. So what was a hidden rule that was playing there that maybe we should have asked as a healthcare provider for Bill whether some of his resources, basic resources, were being met? If we see Bill come back all the time and we see some of those implications of not having his diabetes well controlled, what should we have been thinking about instead of just the revolving door for Bill? So we might want to start thinking about some of those things and think about how we could have talked to Bill to hear his story. So if we talk the formal register all the time, as the physicians seem to do, instead of a casual register, let me hear your story, Bill, let's have a conversation. We've seen you in here, or I see in your chart, you've been in here 6 times over the last 8 months. Is there something that's going on in your life that maybe we need to address that's impacting your diabetes care? Do you think that really happened? Or do you think the conversations were always informal register and Bill always ended up back at the clinic talking to that lovely nurse practitioner and the staff that knew Bill on a first name basis? The idea is I see you, but I don't hear you. So why do we always feel like we've got to communicate with patients in a formal register? Patients like for you to kind of speak to them in a casual, intimate register. I like it when I go to my dentist and they call me by my first name. It doesn't bother me. Vivian, how you doing today? How have your teeth been? You feeling all right? Everything going well? How are the twins? It becomes a personal conversation. I feel that I trust them. They're building a relationship with me. They have a bond with me. And in poverty, those bonds and that relationship is critical. Some of those verbal and nonverbal attributes are critical. So what does it all mean? Well, poverty is concrete. It's a sensory and a reactive world. The medical community is verbal. We're abstract. Sometimes we're not proactive. Sometimes we are. And without language, access, and bridging and bonding capital, we lack the tools necessary to negotiate and manipulate a person's position in the healthcare service. So we've got to think about, as a healthcare entity, how we engage that person, whether they're in poverty, middle class, or wealth. So now I told you, I promised you we'd talk about bonding and bridging social capital again, and here we are. So if you look at this model, you'll see bonding capital and bridging capital. Where do you think people in poverty land? In that green circle or the blue circle? I've got two people in here, so I'm going to ask them to holler out. Do you think people in poverty land in that bonding circle or the bridging capital? People in thank you, Joy. People in poverty land in the bonding capital. They're the get-by people. They're the priority right now. I'm surviving. I need people around me. That support is critical. Bridging capital are usually the get-ahead people. Those are your help, and we're calling bridging capital folks for this presentation as your nurses, doctors, healthcare providers, all of those within that safety net. Now, for optimal health and wellness and patient care, you've got to have a balance between the bonding folks and the bridging folks. So don't you like that? We've all got to, I might make a song about that as I teach the bonding and bridging. But anyway, you've got to have those two audiences for optimal patient care. So I'm going to read you something. It says, the issue for people in poverty is they have very little bridging capital. They don't ignore nurses, physicians, and community educators. They're just not in their circles. You have to partner with folks in the bridging capital in order to engage patients in their care. Someone in poverty finds that voice, they can respect it, they'll grow in new ways, and so will your healthcare system. So we need to think about those things, and how do we impact social capital, and what's its impact on health? How do we get that person in the middle to feel like they need all of those other things on the outside in their circle? How powerful do you think the relationship is between treatment compliance and that social support? So put yourself in the center of that and think about all the people around you, right, that are your support system, and think about where you as a healthcare provider or a healthcare entity feeds into that circle. Now, the solid lines, right, are those foundational relationships. The dotted lines are not so much. And what do you recognize about the dotted lines in this picture? It's your immediate family that you would think would be very much part of your social capital. In many scenarios, they're not, right? It's those friends, co-workers, sometimes other, and look at the brother, they're not even part of the social capital at all. So you as a healthcare entity have to become part of that social capital, part of that social health, either connecting them to a support group, finding them home health services, being a health coach, being a provider of some sort, connecting the dots for them. That's how you become part of their social capital. And then you have to recognize that people you assume are, and there's that word again, we make assumptions, right, with our patients, that they have the family support, the husband, the daughter, I've got the mother, you know, all of that as a cohesive unit, making sure that Bill stays compliant. We'll put Bill in the middle of that circle. Do you think that might have looked a lot like Bill? Maybe the wife in place of the husband there, maybe he has a daughter or a son. They're not very supportive of him because they've got their own issues to deal with. So we have to think about people and what comes with people as we think of them as patients. So there's that bonding and bridging capital that's going to support my change. I'm going to change the way I go about my diabetic care, I'm going to be more compliant. I'm going to take my meds. We're going to find me an affordable medicine to take that I can afford, that my insurance plan will cover, or that's on my drug list that I can pay for, and we're going to make sure that this works. This is the only way that Bill is going to achieve better care for his diabetes. So how do we check that to make sure that we're thinking about that as we see our patients? So these are the questions again. How powerful do you think the relationship is between Bill's compliance and his social support? And how are you doing at building relationships with people like Bill to earn their mutual respect? And how do you think small changes could have a positive impact on Bill and his care and the cost of his care? And how do you address the low social capital of patients in poverty and how that'll probably have a negative impact on the outcomes of your institution as it relates to his diabetes care? How could building social capital by adding just a diabetes educator or a wellness coach or a diabetes support group improve the quality of his care and bring down the healthcare cost of your institution, especially if you're a hospital or if you're a clinic? Would your patients and clients say that you and your staff are successfully bridging social capital? So that's going to be something that I want you to always think about. Think about how you can bridge social capital within your institution or agency. Now this is the efficacy to action tool. These are all the pieces of the puzzle that you need to do this. And you're going to say, well, I don't have any influence on some of those. You're absolutely correct. But this model is to be shared. It's not for you to sit on and just hold for yourself. This is for the COO or the Chief Operating Officer or other folks that can make those policy and procedure decisions to think about how they're being effective how they're having effective patient care in their community. So let's look at the far left. It talks about what's needed as it relates to community assets. We all know with our patients, child care is critical. Whether they're employed or underemployed, their physical and built environment, their neighborhood, their social and cultural determinants, where they live, where they learn, where they work, where they play. Their geodemographic segmentation, meaning are they isolated? Are they isolated within a certain pocket of a community? Civic engagement. Do they feel like they really have a voice? Do they feel like they have any power at all? Most times people in power don't feel like they have any. And then we need to think about this top piece of the puzzle as an entity. And a lot of our agencies have done a lot of things with reducing the complication of forms, taking health literacy into account, the hours of operation. Some clinics stay open later, certain days. Some have even gone to Saturdays. Redundant questions and processes. How many of us have answered the same question on 10 different forms? We're trying to do better with that. And we're working on cultural humility and cultural sensitivity with our staff. Sometimes we're not very welcoming as an entity. We don't make people who are in poverty or who are in different classes feel very welcomed, right? We have such a judgmental sometimes attitude. Fragmentation of care. How you go here, how you go there. You need to go over there, Mr. Johnson, because we can't do that here, but we can send you over there, and you need to go to this clinic for that, and you need to go over there for that, and you need to go over here for that. We're trying to do a better job of under one roof providing one place for people to find all of their care. And then we're trying to reduce the delays in getting appointments, excessive time in the waiting room, and bills that are just difficult to understand. So that's where the management part of your healthcare facility needs to see this, how they all fit into this puzzle. The last part is how we address some of these non-compliant issues, the no-shows, the recidivism into the emergency room, giving false information, substituting prescribed care with taking different friends and families' medicine because they can't afford the one that you've prescribed, late for appointments. All of those things are fitting into the puzzle on being a more efficacious institution. So how do we achieve that, right? So we have to have the capacity to make these changes at all three levels again: institutional, individual and community. And do you have a policy in place at your healthcare institution to support that? So here's the institutional resources that's needed to do this, right? And here are the hard questions. Do you have the right staff or people at your healthcare institution? And a lot of agencies are looking at that. Do they have people that are compassionate? Do they have people that are mission-oriented? Is your facility designed for all the different types of people that walk through your door? Is there clear signage for those that maybe have difficulty with reading levels? Is it well maintained? Is it clean? Is it a safe environment? What about financial? Is it well funded? Do you have reserve funds? Do you have some funds set aside for folks who may not be able to afford the first round of medication? And what do you do about technology and data, right? How do you keep up with your patients? Do you have reminder systems in place? Do you have other social media things that people can use on their phones now? Do you have mobile apps related to your healthcare facility so that people can connect with your healthcare organization? What about the culture of your healthcare organization? Is there ethical learning within your organization? Does it help foster leadership to empower you to be more efficacious as a healthcare provider? What about your environment? Is it nurturing? What about your community relations? Do people in the community know you personally? Do they know who you are? Are you creditable? And I can't say enough about being a trusted partner, because people want to know you care. They want to know that when they walk through the doors, they're going to get the best care possible. So when we think about Bridges to Health and healthcare, we think about this model. And I like this. It's a little busy, but I like it. And it's just looking at all that's involved in continuum of care for a patient. Put the patient in the middle. And you'll see our three words again: the individual, the institution, and the community. And then what's in red is the driving factor that influences some of all these other things, is policy, right? What do we have in place? Is it a barrier to giving the best care to that patient? Is it some kind of institutional policy that's been in place for the last 10 years and we don't really know why it was there, but it's been there, and I guess we have to keep doing it because it says we do? And sometimes you need to look at what policies are in place and modify them and adjust them according to the needs of your community, not just because you're a healthcare entity and it says you have to do this because it's always been done. So think about the outer circle and all of those folks that are at the table to make sure that this community and Bill, as part of this community, stays well. Did you ever think that criminal justice would need to be at the table, or government, or the faith-based community, or education, or business? All of those people need to be at the table. Those are the prongs of your table to help build up. That was a tongue twister. But all of those need to be legs on your table to keep Bill healthy, for him to feel like he's part of this community. And then you have to recognize within which class Bill falls. Because in order to talk to Bill and relate to Bill, you have to know which lens he's looking through. Is he looking through the middle class, the poverty, or the wealthy? All right? And you have to be able to recognize that. And I can't emphasize that enough. And then, of course, look at our outer circle. And what do those words remind us of? Those were on the top part of the grid, those things that we talked about: access, availability, cost, quality, communication, and efficacy. All of those wrap it up in a nice bow. So those are the things that we have to think about as a healthcare entity in impacting the health and wellness of communities, and not just Bill. Because Bill's just one person, right? We've got to start thinking about the community as a whole. So all of that is social coherence, what we call making a community what keeps it together, the glue, right? So does a person have a sense of being linked to the mainstream of society? Do they feel like they're a part of the dominant subculture, or being in accordance with the main society's values? Can a person perceive society's message as information rather than just background noise? You know, the womp, 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 womp. Is Bill hearing that? Or is he really hearing an informational message that shows that people care about Bill, they want to see him healthy, they want to see him thrive and survive, right? People in poverty usually think the latter. They usually think and interpret what you're saying to them as noise. Do they have a resource to carry out the plans that you've given them? And can they get meaningful feedback from society? Do they feel like their messages make a difference? And there's that voice again. Are you hearing Bill's story? Are you listening to what he's saying in order to make changes within your system to take better care of him? So you have to build relationships and social coherence to have an effective practice. So you've got to decrease that background noise, retool you and reframe your health messages and using the mental models we talked about, right? Those mental models for poverty, middle class, and wealth. And then you've got to embed a relationship of mutual respect, understand some of the hidden rules, right? Establish your voice, increase perception of the patient's hierarchy in the clinical process. I hear you, Bill. I'm listening to what you're saying. Design effective forms and procedures and let them be standardized within all departments to where you quickly engage the community and they don't feel like they're spending all of their time as just paperwork for you. Use a brief assessment tool to determine if a patient has the necessary resources to follow up on their treatment plan and whether all of those things that Bill needs to be connected to can happen. Does he have the resources? Does he have those tools needed to do that? So how do we develop a Bridges community in addressing healthcare? So this is a busy slide too, but I think it has everything that we've talked about today tied together. The purpose of Health into Healthcare was to bring all classes, races, sectors, political persuasions to the table to address poverty and create sustainable, viable communities. And we said in order to do that, you've got to think of how to do it with data, how to do it with research, how to evaluate what we're doing, how to make it part of our QI process within our healthcare institutions, how to create critical mass to not just impact Bill, but everyone, and how to maintain those critical bridges for health and train others to recognize those things. And then think about the strategies to do that. What has to happen? Well, your organization can't continue to think the same way. You've got to engage the whole community and not just Bill and those that walk through your door. You've got to support a transition if it's needed, a transformation that needs to occur. You need to build your resources. You need to have an administrative agent to kind of oversee everything as these changes are made. It needs to be stabilized so it can be a healthy environment. You need to have a fiscal agent that keeps track of the dollars and cents. And then you have to have a collaboration. Remember those 8 prongs at the table that I told you, those 8 feet that are part of your table? That's the collaboration piece. And then think about the potential champions that you need, right? That outer ring. Those are your legs. You can't do it without them and be successful. And that's what Bridges into Health really is showing you how you can be successful using the Bridges lens and having a more efficient, streamlined, effective healthcare agency to impact patients like Bill. And Bill was just one patient. I could have used anybody else. I could have used a Sarah, I could have used a John, I could have used anyone else with a number of health issues. And the message would have been the same. So how do we courageously cross this bridge? So it takes a lot for you to kind of come out of your bubble. It takes a lot. It takes courage to release us from what we've been doing the same and what we're familiar with. And embrace something new, right? But there's no real security in what we do, and it's no longer meaningful if we're not having an impact. So there's more security in the adventurous and exciting. For in movement there's life, and in change there's power. And for that I thank Alan Philip Cohen for that quote. And I thank you today for allowing me to share a little bit about Bridges into Health. And like I said, I crammed a whole day of exercises and activities and things that we talk about into an hour. But I thank you for letting me do that. I'm available at any time. I think Joy has my contact information. If you want to know more about it, want to know how to set up a training, want to learn more about Bridges into Health, want to have us come out and do a Bridges into Poverty and then a Bridges into Health, so you can kind of connect the dots, all of that works. Just let me know. Are there any questions? Or have I just bored you to death and you're asleep? All right. Thanks again. Oh.
Thank you so much, Vivian. We'll get the camera adjusted here too in just a moment. We're going to go ahead and hand the mic over to Benita Decker, who is the Family Planning Program Director. She has a few program updates, particularly about the training calendar, I believe. She's going to talk about that some, and anything else that she wants to, feels like we need to update you all on regarding the Family Planning Program. So thank you very much, Benita, for being with us today. You've got your pretty Christmas sweater on. So she's going to adjust the camera there. Yeah.
Hey everybody.
That's good. Thank you.
Wouldn't be a PHM webinar without at least one comment from the Family Planning Program. So thank you all for taking the time to listen to me. It's just two small items I want to chat with you about. The first one, actually, before I hit the training calendar, is the INE Committee and Community Participation Committee Toolkit. I've had just in the last few weeks I've gotten some minutes in for people who are having their committee meetings, and that's awesome. I also have had some questions about where do I get the toolkit? Well, one, you can get it from me if you email me, but actually it's out online. It is on the local health department information homepage. That homepage that's provided by the Department for Public Health. If you look at that right column as you're looking at the page, there's some resources, and you see the AR and the CCSG, and there's a whole list. At the very bottom of that page is the INE Committee Toolkit. And so, but you're more than welcome to email me. I'll be glad to send it to you, but you can go out there and grab it yourself if you need it. The cool thing about that toolkit is that it's got some templates at the end that helps you. It defines what you do, but it also has some great templates that you can use to evaluate new posters and brochures and information, and to evaluate outreach activities, things like that. So feel free to ask, email me, ask me any questions about it. But I just wanted to kind of let you know it is out there in cyberspace if you need it. So that's all I have about that. But I do need to talk to you about the training calendar. Some of you have already let me know, and we found that, there's that list of things that you have to train on, especially as a new orientee, or your new orientees need to train on. Well, it turns out 3 of them are expired. 3 of those courses are expired. Those 3 are the mandatory reporting, the folic acid, and the cultural competency. All 3 of those courses have expired. We are in the process of revamping those and renewing those. In fact, I hope within the next week or so, we're going to change the folic acid training to a preconception health counseling training. Same stuff, just kind of broadening a little bit and giving you an overview on what preconception health is. I mean, I know you know what it is, but what it means to truly counsel your patient and what all is involved. The mandatory reporting is going to change to a 3-module, short 30-minute 3-module course that will be a little module on child abuse, a little module on adult abuse, and then one on human trafficking. And so the new orientee or anyone needs to take that course, but it'll be in 3 segments where they don't have to sit for an hour and a half and listen to everything. They can take those in little pieces and slices. Those courses should be available. We hope our goals by the middle to end of January. We're working with the Department of Community-Based Services and some other folks to get those modules done, and so they're going to take a little bit longer. And then the cultural competency course, we're almost ready to put that out too, and so I will notify you when those updates come. Meanwhile, if you have new staff, oh, and the other thing I want to tell you is that one of the courses that was on there was called Title X Orientation Program Requirements for Title X Funded Family Planning Projects. We are removing that course from the required course for orientation because that Family Planning Basics course that we've added about a year ago or so. It covers 90%, definitely all the core information in that Title X orientation course, so there's no need to take both courses. So, so what new orientees will need is they'll need that Family Planning Basics course, which also has to be repeated within every 3 years by all your staff. It's a great 5-module course that I took it again just a few weeks ago because the site's new and I wanted to make sure they hadn't changed it. And I learned every time I see it, I'm reminded of stuff or learn stuff that I didn't think about before. So it's a great refresher course and an orientation course for your staff. Make sure you take that. The nice thing is that the National Family Planning Training Center, which is really called the Family Planning National Training Center, I get my acronym messed up, has changed their website. And they've updated it. They had a new, they awarded a grant to a new group that used the same website, but it's updated. And it used to be if you wanted CEUs for that course for 2 hours of CEUs, you had to pay $12. That's not true anymore. Now you get those CEUs for free. And so you could always get a certificate, but now you can actually get 2 CEUs for taking the course, which is really good. And then also, if you notice, if you get on that Family Planning National Training Center website, and you think, I have an account, and suddenly it's gone, they've had some real technical difficulties with that, so they've asked you to re-log in, to create a new account. If you can't log in, they said some people are able to, but a lot of people, their old account doesn't work, so you may have to create a new account. But it used to be that the old system did not track your learning. But this new system does. It gives you your My Learning, kind of like Train does. And there's a ton of great courses out there on the Family Planning National Training Center site. None of the other stuff on the training calendar has changed. I will send out an updated training calendar once we have all this orientation stuff fixed. And so we will get that out. Meanwhile, if you have any questions, if this is as clear as mud, feel free to email me and I'll answer your questions. But just know that for right now, until we get these other courses up, your new orientations have to take that Family Planning Basics course, and then once the other courses come on board, they can catch up. And also, once the other courses come on board, your seasoned nurses and staff can also take those courses because they won't have taken them before, and they'll be good refreshers for them. So they'll be also listed in the rest of the calendar for things that they can choose from during the year. Is there any questions? That's kind of a lot in a little bit. Okay, great. Well, you all have a great holiday and holidays, I guess. And I'm sure I'll be talking to you on email and see you next year at the next PHNRTV.
Thank you, Benita, for those updates. Okay. We're running right on schedule, so we're going to go ahead and wrap up the webinar today with some nursing office updates. I wanted to share with you, first of all, that I did send out with the agenda for today's webinar the 2018 PHN webinar dates. So if you'll go ahead and mark your calendars for those, they're every other month. Third Thursday, 9:30 to 12:30, and of every other month. So our next public health nursing webinar will be on February 15th. So we'll have been through Christmas and New Year's and Valentine's Day before we meet again. So those dates are now set up, and we'll be meeting here in the same location, and you can go ahead and plan on us being here. I wanted to share also with you all that the NEC, and I believe I mentioned this last time, the Nurse Executive Committee's focus this year for our charter is really on trainings and training opportunities and for local health department nurses. And one of the areas that we've identified as having some needs is our Division of Laboratory Services and our CLIA certification. And so we will be collaborating with the Division of Laboratory Services, Dr. Hart and his team. And we're working right now with the NEC to kind of prioritize a list of training needs that we're going to ask the Division of Laboratory Services to assist us with. I also reached out to the Office of the Inspector General, and as you may know, they are the responsible entity for the monitoring and oversight of CLIA certifications across the state. And so they're housed under that umbrella. That responsibility is housed under the umbrella of OIG. So Marla Lyons, who is one of the CLIA inspectors in the western part of the state, she spoke to the NEC at our last meeting in November, and she shared with us 2 resources that I really think will benefit us as far as it relates to QA checklists. There's some orientation information. There's quality assurance examples of tools that one could use, and they're split up. The two documents are split up for waived CLIA waived labs, and then there's one for PPM lab CLIA labs, which is provider performed microscopy procedures. So those and local health departments either fall into one of those 2 CLIA certifications. So I'll show you this one. This is called Ready, Set, and Test. And this is produced actually by the CDC and the Division of Laboratory Services. So I'm trying to make it be straight. There you go. So Marla brought these by, hand-delivered these books to me just yesterday afternoon. And so I'm going to speak to Marla or the CDC and see how we can obtain more of these books. They're excellent resources, I feel like. And so we can go ahead and start. Either I can place an order with CDC or I can get some printed, so we can have one a minimum for all 120 county sites. And so that's the one, Ready, Set, and Test is for the waived testing. And then here is the booklet. There's one, and it's a lot fatter, but it's on the PPM CLIA certification. So these, I did not know these resources existed, and so I appreciate Marla from the OIG sharing that information with us. And so we'll be getting this out to all local health departments, and I'll probably reach out to the nurse leaders with this information. And if CDC doesn't have enough copies for us to have 120, then I'll see if I can't just get some printed here and share those with you all. So you can look forward to that. In the meantime, I do think that you know, there will be other opportunities that we can work with the Division of Laboratory Services as far as some of those needs that we've identified through the NEC, and hopefully we'll be able to provide a section in the administrative reference that will provide basic orientation information, QA information, you know, guidance about CLIA certification and recertification through these manuals and the CDC guidance. So you all, as nurse leaders and nurses in local health departments, will feel comfortable and competent with providing laboratory services within your agency. Certainly, you all will still have contracts with your reference labs in your agency, but for those services that you all provide on site, your UAs and pregnancy tests and your wet mounts, those we want to be sure that you all have the resources and the tools to provide those services, quality services. Any questions about that information? It's like I got an early Christmas present. That's a gold mine, treasure trove of information there that was not aware that it existed, and so we're going to be sure to get that out to you all. Okay, next I just wanted to mention a couple other things. I did receive an email from Sarah Jo Best, who is the director of the Lincoln Trail District Health Department, and she's the point of contact, the lead for next year's 2018 KPHA conference. And so she shared with me the date and time for the KPHA Nurses Luncheon, which is going to be held on Wednesday, April 25th from 11:15 to 12:45. So I'll be working on a speaker for the luncheon, and I hope that you'll, if you're going to be attending KPHA, that you'll be able to attend the lunch as the nursing office guests. And we will have a CE available for a presentation for that day. And this year the KPHA conference is going to be held in Northern Kentucky. So that'll be a change. In the last couple of years it's been in Owensboro, so I think they're trying to kind of rotate those sites. So April 25th, 11:15 to 12:45 will be the date and time of the KPHA Nurses Luncheon. And then one other update I wanted to share with you was we're working on the annual Women's Health Update with the Division of Women's Health and the Madison County Regional Training Academy. And so we'll be, actually we're going to meet tomorrow to begin our conversations about the agenda and speakers. So if you have any ideas or on topics that you all would like to know more about, learn about, please let me know. That date, we're hoping that we'll be able to use that April 19th PHM webinar date and have that kind of serve as a dual purpose. And it'll be a 3-hour training, and if we can use that for the 3-hour PHM webinar, that'll be real convenient, I think, for everybody. And so we're going to be identifying speakers, and based on their availability for April 19th, that's the date that we're going to hope that we'll be able to host that event. Otherwise, we'll have it on another date and be able to take that and have it available via archive webcast. So I don't see any questions, Joa. Okay. We're going to end a few minutes early today. Thank you all so much for all that you do each and every day. And I wish you and yours a very warm and happy and healthy holiday season. And we'll see you in 2018. Thank you again. Take care.